In this class, we will deal with the sequelae and complications of uveitis. Uveitis is an important cause of blindness. In the developed countries, it is the fourth leading cause. The more common complications of uveitis are cataract, glaucoma, cystoid macular edema, and hypotony. Inflammation in the uveal tract is uveitis. This results in exudation and cellular infiltration of the uveal tissues. The tissues are iris, ciliary body, choroid, and the retina. The consequences of this exudation and cellular infiltration is organization of the exudates and the fibroblastic activity. We shall deal with the sequelae as occurring in each of the tissues as iris, ciliary body, lens, vitreous, and the chorioretina. Iris. Organization of the exudates in the iris can result in addition of the iris to the neighboring structures. An addition of the iris is called as Sequelae. It can be anterior to the cornea or posterior to the lens. The exudates can also organize as fibrous membranes. When the pupillary margin adheres to the lens, we call it as posterior Sequelae. The sticky iris can also stick to the anterior part, that is the cornea, at the angle where it is closest to the cornea. This is called as the peripheral anterior Sequelae. When the entire posterior surface of the iris gets attached to the lens capsule behind it, we call it total posterior Sequelae. This is a diagrammatic representation of posterior Sequelae. The pupillary margin is closest to the anterior surface of the lens. It's very easy for the pupil to stick to the anterior part of the lens. It can happen in single areas or multiple areas or all the 360 degrees. So the diagram represents an inferior posterior Sequelae. In these photos, you can see posterior Sequelae. In the right photo, there are multiple posterior Sequelae. When a pupil dilates, the areas of posterior Sequelae, if they are permanently adherent, will not dilate. But the areas in between the Sequelae will dilate. This gives rise to an appearance of the pupil called as a festooned pupil. When the pupil is adherent to the lens in all the 360 degrees, this is called a seclusion pupillae. The anterior chamber and the posterior chamber do not have a connection because of the adherence of the pupil to the lens. Such a Sequelae occurring 360 degrees of the pupil is also called as ring or annular Sequelae. The other part of the iris which can get adhered is the peripheral iris. The peripheral iris is very close to the cornea at the angle of the anterior chamber. Here it can get stuck to the angle, and this is called as peripheral anterior Sequelae. The diagram represents peripheral anterior Sequelae. This closes the trabecular meshwork and the pathway of the aqueous is blocked. This photo shows areas of peripheral anterior Sequelae in the nasal part of the iris. This is a diagram which demonstrates total posterior Sequelae, when the entire posterior surface of the iris is plastered on to the anterior surface of the lens. What are the consequences of posterior Sequelae? Adherence of the pupillary margin to the lens in all its 360 degrees causes seclusio pupillae. The aqueous normally drains from the posterior chamber after being secreted by the ciliary body through the pupil and from the anterior chamber via the trabecular meshwork and out of the eye. In case there is a seclusio pupillae or the annular Sequelae, there is what is called as pupillary block. The blockage is to the drainage of the aqueous from the posterior chamber to the anterior chamber. The aqueous collects behind the iris and this balloons the iris into the anterior chamber. So the anterior chamber shallows. Such an iris is called as iris bombay. The ballooning of the iris gets the iris closer to the cornea in the periphery. In fact, it closes the angle of the anterior chamber, and this is called as secondary angle closure, which results in glaucoma. So this is a result of extensive posterior synechiae. This is a diagram which shows iris bombay. Note the iris which is ballooned into the anterior chamber, shallowing the anterior chamber, the cause of which is 360 degrees pupillary synechiae, which finally results in angle closure at the periphery. This is called as secondary angle closure, glaucoma. What about the consequences of peripheral anterior synechiae? Peripheral anterior synechiae block the angle or close off the trabecular meshwork, resulting again in the blockage to the aqueous drainage from the eye. This again leads to increase in the intraocular pressure and secondary angle closure. It is therefore very important to do gonioscopy to visualize the angle in every case of uveitis. When there is extensive exudation in the iris and ciliary body, another term used is plastic iridocyclitis. There is formation of membranes by the organization of these exudations. These membranes can occur over the pupil or can occur in the retrolental space. This is a photo which shows a pupillary membrane. The pupil is now occluded by a fibrous membrane. Such a pupil is called occlusio pupillae. The result is again pupillary block to the drainage of aqueous, iris bombay and secondary angle closure. The yellow discoloration or the yellowish membrane that is seen in the pupillary area is not cataract because it is seen across the pupil and not behind the pupil. The pupil itself is irregular because of the contraction of this fibrous membrane. Pupil block will again give rise to secondary angle closure, glaucoma. Fibrous membranes can occur due to extensive exudation of the ciliary body in the retrolental area, just behind the lens. Such a membrane is called a cyclitic membrane. It's an exudative membrane which is organized behind the lens at the vitreous base and the pars plicata of the ciliary body. This results in decreased production of the aqueous and hypotony. It can also contract and pull the retina and result in fractional retinal detachment. Long-standing cyclitic membranes can result in atrophy of the ciliary body and permanent reduction in the production of aqueous. Ultimately, this results in a shrunken, sightless eye. What are the changes occurring in the pupil in iridocyclitis? We have already seen this. Let us just do a recap of that. It can be small, myotic. Posterior synechiae can cause the pupil to be irregular. In all the areas it is adhered to the lens, the pupil cannot dilate, but will dilate in the areas in between, giving rise to a festooned pupil. 360 degrees ring synechiae or annular synechiae is also called as seclusio pupillae. When the pupil is occluded by a fibrous membrane, it is called as occlusio pupillae. Another change which can be seen in the pupil in uveitis is ectropion uveae. This is a diagram of ectropion uveae. When exudation on the anterior surface of the iris gets organized and it contracts, it can actually pull the posterior pigment epithelium of the iris forward around the pupil, resulting in dark brown pigmented area around the pupil on the anterior surface. This is called as ectropion uveae.